Hi, welcome to Living Healthy. I'm your co-host, Dr. Barton Bishop, and with us as always is Dr. Jay Greenstein. I'm the Chief Clinical Officer of Sport and Spine Rehab and also have my doctorate in physical therapy. And Jay over here is the CEO and founder of Sport and Spine Rehab and a chiropractor. You know, over the last year or so, we've brought you many different shows on living healthy, from first fighting obesity through fitness and weight training, to then talking about Steven Strasberg's right elbow and Robert Griffin's right knee with prominent orthopedic surgeons. And most recently, we had a discussion on clinical research and athletic training, and specifically concussions in the youth athlete. Well, today we're going to shift gears a little bit, and over the next couple of shows, we're going to run a mini-series on something called healthcare reform. I'm sure you've heard of it. It's pretty prominent in the news. You know, this healthcare reform is obviously a really big issue. And first of all, Kirill, I just want to talk about what was the initial impetus. Why did we have this? It's not like President Obama just said, oh, healthcare reform. What was the driving force?
Sure, and if you remember, I mean, this was a big part of his campaign as well when he was campaigning in 2007, 2008 for the presidency. Healthcare reform is something that I think every president has tried to tackle since Truman and Eisenhower. I mean, we've been talking about this for a long, long time. And the reality is I think it's universally agreed to that if you have more people who can access medical care, you will have a healthier society. And if you have a healthier society, you have a more productive society, and society will, the economy will grow, the economy will flourish, people will be healthier, and in general, it's a better place to be. So I think this was something that he decided to tackle as one of the main points of his presidency in his first term. And unlike the previous 6 or 7 presidents, was actually successful in passing legislation.
So then, specifically related to you and your being here, why are you here? Like, in other words, what is your relationship within healthcare in the Maryland delegate?
So I serve, I do represent District 39, which is parts of Gaithersburg, Germantown, Montgomery Village, and Clarksburg here in Montgomery County. But I also serve on the Health and Government Operations Committee in the House of Delegates. And the Health and Government Operations Committee has jurisdiction over all matters of health care, whether it would be insurance or any kind of coverage, whether it would be professional licensure, facilities regulation, whatever it may be. The HGO committee that I serve on is responsible for it. There are 3 members of the Montgomery County delegation on that committee, and I have been on there the longest.
That's great. So Hadley, welcome. Thanks for being here.
Thank you.
And tell us a little bit about your background and your involvement with healthcare reform.
Great. I am a North Carolinian, but when I graduated from college in 2010, that was the same year that the Affordable Care Act passed. And it was also a time when I was starting a job in the public policy world. And my first week on the job, I spent the entire week with the text of the legislation in front of me.
It's like 10,000 pages, right?
It's a very lengthy piece of legislation, very complex. I agree with Kirill that there was an impetus, especially politically, to get something happening in the health reform of our great American system. Because really, there are some great things about our healthcare system in the United States. We have some of the best quality healthcare in the world. We have one of the most innovative systems in the world, and we also rank very highly in terms of responsiveness to the individual needs of the patient. But we also spend more money per person on healthcare through a variety of, patient out-of-pocket costs, third-party payment costs, and a huge amount of our government expenditures are dedicated to health insurance programs and health subsidies. So we definitely need to reform that payment system to make care more accessible and more affordable. I have been a critic, though, of the Affordable Care Act and its attempt to do that. I'm afraid it's the wrong direction and doubles down on some of the policies that got us into an expensive, bloated system in the first place.
So if you wave the Hadley magic wand and you're able to make changes, what would you do?
Well, first, I think if I were the queen, yes. If I were president, I would work to repeal the Affordable Care Act because I think it was a step in the wrong direction. But I would also institute some health reforms that would encourage more competitiveness in health insurance and in health care. I would allow individual patients or encourage individual patients to have more transactions with their individual providers. So I'd try to scale back the role that third-party and multi-party payers have in our system, because, when you're not paying for something with your own dollars, there's a way that third-party payers can take advantage of those reimbursement setting rates, and there's a way for them to get in between us and our doctors. Now, I am in favor of everybody, I encourage everyone to get health insurance of some kind that prepares them for a catastrophic event in their life. But the requirement in the Affordable Care Act that everyone buy health insurance is more than just that. It also dictates the minimum essential benefits that every policy has to have. And I believe that that's too comprehensive for the needs of most Americans. Most people want to have some flexibility and pick and choose what's in their own plan.
So let's talk specifically about essential benefits. And essential benefits is something that is the word's thrown around a lot. Specifically, what is or are the essential benefits?
So, in general, the essential benefits are a basket of benefits that are a minimum requirement for you to get. There are 10 categories established by the Affordable Care Act as to what those minimum benefits are, and each category is really that. It's a category. It's a pool of a variety of different requirements that must be offered on a health insurance plan. If you take a look at the 10 pools, if you take a look at the 10 categories, for the most part, you will probably find just about everything in those 10 categories that the average person will ever really need in their lifetime. And I say that as somebody who's actually been a critic of the essential benefits because it doesn't include a particular category that I have been an advocate for. And so
Which is what?
Which is behavioral therapy for kids with autism. That's been a main part of my legislative agenda for the entire time I've been in the legislature, and that is actually a benefit that's not included. It is can be included by some states. So, for example, the quirk to the way that the regulations were established in terms of the essential benefits were, it's either the essential benefits, or if a state already had a pool that it can draw from depending on its own plans, and it's a lot more complicated, but I don't want to take the time to go into the detail. But a state can establish its own essential benefits if it doesn't counter. So if the state already had adopted the behavioral therapy, it can be included. Maryland, unfortunately, had not by the time the regulations were adopted. So for me, it is an issue. But for the most part, it's pretty much any benefit that you would probably need.
Another way to phrase essential benefits is coverage mandate. And there were coverage mandates. Some states had dozens upon dozens of coverage mandates. Some states had very few at all. And we can see, looking back to the world before Obamacare, that even then, states that had more coverage mandates, that correlated to higher premiums in those states. And it's not surprising, the more coverage you have, the higher your premium is going to be. I just believe that should be a choice left to individuals and their families rather than a state-level mandate.
That's interesting, though, because if you take a look at Maryland as an example, Maryland was actually the state with the most mandates on the books. Maryland had more mandates on health insurance than any other state in the country, more than California or New York, which also top at that list. And yet, when you look at the rates that have been proffered by the Maryland Insurance Administration for the exchange that we'll talk about probably in a few minutes, you'll notice that they're actually some of the lowest in the country. So even though Maryland was able to adopt all of the existing mandates on health insurance, we're still being able to produce a product that's very affordable.
So what are the factors that go into producing that product? Because there's the essential benefits or the mandates, right? And there has to be other things. There has to be quality. There has to be numbers of providers, population density. What go into that besides just the essential benefits?
Well, like in previous times when we set rates for the insurance companies.
Are we calling this like PO, as in pre-Obamacare, as in, A, B, B, C? We call it PO, but it's Barack Obama.
Right, yeah. Just like in previous times, an insurance company, and like really any insurance company, it has actuarial specialists on their staff who create billions and billions of charts that go into determining what costs should be. They then provide their proposals to the Maryland Insurance Administration, and this is the process in Maryland, which I'm obviously most familiar with. And the Maryland Insurance Administration will take a look at those numbers, analyze them, make sure that they are fair, and then they will either approve or disapprove or do some hybrid in between of those rates. The same process went to determine the rates that would go into the exchange rates for that pool of benefits, or for that pool of plans that will become available. It works the same way for our utilities, whether it's our gas, our electric, or our water. It works the same way for insurance companies.
But it seems counterintuitive to be like, I'm listening to Hadley, I'm like, okay, that makes sense. Yeah, the more benefits you have in a plan, the higher the cost. But yet in Maryland, what were the variables or factors that were able to bring those costs down, or at least to an affordable level? What happened in Maryland?
Well, part of what you have in Maryland is you have a system that is trying to bring down the costs in a number of different ways. So, for example, we have an all-payer system for our hospital system. I don't know if you're familiar with. This was something that we had put in the 1970s, and it is a system that says that everyone is responsible for the care at the hospital level. The state kicks in, the insurance companies kick in, the hospitals kick in, and the providers and the patients kick in. And because of that, we end up leveling out the cost, and of course the federal government kicks in with regard to Medicaid as well. We end up leveling out the cost, which significantly brings down the cost to everyone, because hospitals are such a huge part of the medical costs in the state.
So I'd love to hear from you, because I'm hearing the federal government kicks in, and that increases cost.
Right. Well, Maryland taxpayers are also federal taxpayers, right? So anytime we hear about the federal government kicking in, it may sound like a good thing at the state level, but ultimately it's the same taxpayers who are paying for the subsidies. When it comes to the Maryland rates, I know in April, CareFirst was requesting one of the biggest rate increases in the country, asking for like a 25% rate increase, especially for people who would be getting their individual insurance or insurance through the exchange. And the reason the rates aren't going to be that high is because we have a rate setting process in the government. And rate setting, comes with other unintended consequences. For example, Aetna's not going to be offering coverage in the exchange anymore. So if you make it unaffordable, or you make it less profitable for Aetna or other insurance carriers to participate in the exchange, then that's one fewer option for people in Maryland who are seeking to buy their own individual insurance.
And that reduces competition, and that can't be a good thing.
It's not a good thing.
Yeah. So we've heard about exchanges. Briefly, we've talked about essential benefits mandates. What is the exchange?
The exchange, there will be 51 of them, because each state will have one, and then the District of Columbia will have one as well. These are government agencies, basically, that exist to do several things. For one thing, they act as a clearinghouse for individuals who are seeking to buy health insurance. And the idea, or the goal, is to have similar information available about plans so that shoppers can, be matched with an insurance carrier that offers a plan that's right for them. But they do several other things as well, things that look less like the role of a marketplace or a clearinghouse and look more like a government intervention sort of role. And that is, they work with employers in every state to monitor who has health insurance and who doesn't, who is employed and who isn't. And these are real-time monitoring mechanisms for people in terms of employment and health insurance status. And then they help to deliver subsidies to people at 400% of the federal poverty line or below, or at least down to a certain level before you reach there's a gap, and then people can qualify for Medicaid. But this subsidy delivery works, it's sort of giving with one hand and taking with the other, because if an employer is of a certain size and doesn't provide health insurance coverage, or doesn't provide affordable health insurance coverage, then that employer may be subject to additional taxes through the employer mandate penalty and so on. So the exchanges are really a government entity that is there to monitor who has health insurance and who doesn't, and to turn in a list of people with their tax ID numbers to the IRS so that these mandates can be enforced.
When we return, we're going to talk a lot more about national health care reform. Thanks.
A single ember that escapes from a wildfire can travel more than a mile. That single ember can ignite and destroy your home or even your community. You can't control where that ember will land, only what happens when it does. Get Fire Adapted now at fireadapted.org.
Welcome back to Living Healthy. We're here with our awesome guests, Hadley Heath and Kirill Reznick. Guys, this has been a great discussion. I've learned a lot myself, and I know the folks out there have learned a lot as well. I want to get back to the insurance exchanges. Mm-hmm. And it's interesting because I never knew that they actually monitored the folks that might not get insurance through their employers. There's some employer mandates that have changed as well. I know employers are responsible, I guess, to provide health insurance for their employees, but those mandates have changed. So can you talk a little bit about that?
Right. The White House announced in July that they would delay the employer mandate by 1 calendar year. And this is a significant provision in the law. First of all, my gut instinct was I don't believe the White House has the authority to delay this significant provision of the law without congressional approval. And the House actually passed a bill that would delay the employer mandate by a year, but it's stuck. The Senate hasn't taken it up. So that's where we are in the U.S. government. But if the White House successfully gets its way and can delay the employer mandate for a year, this creates some other questions and concerns about the implementation timeline, because the employer mandate is one of the working parts that allows the exchanges to work to verify data on people's incomes. And the household income for each person who applies for a subsidy or applies for health insurance in the exchange, it's very important information, because your household income for a year will help determine what level of subsidy you qualify for, because they are means tested. And without that data verification in place, it's opening a door for fraud and abuse, of course, when people are relying on an honor system for people to report their household income. But worse than that, the law actually institutes a program called navigators, which will hire people basically to function as health insurance agents on behalf of the federal government to inform people about their health insurance options and help them sign up. But the incentive is for navigators to sign up more and more people, even if they don't qualify for subsidies. And at the end of a year, if someone has received a subsidy that they're not eligible for, that money doesn't go to them. It goes to their insurance company. And the individual who received the subsidy will be maybe on the hook for serious fines from the IRS for fraud, and then have to maybe face an audit or a clawback of that money.
Wow.
Well, let me clarify about what's going to be happening here in Maryland, though. As Hadley mentioned, there's going to be 51 separate exchanges. Each state sets up its own. And in fact, it's not always going to be a government agency. The federal health care reform bill gives each state discretion to set up the exchange in any way they want. So if they want to set it up in a nonprofit organization, they could do that. If they want to set it up through a for-profit corporation, they can do it as well. In Maryland, we have set it up as a part of the government agency, as a part of the Department of Health and Mental Hygiene. And it has been set up to not necessarily collect data on any particular individual. The Maryland Healthcare Exchange, which will be called Maryland Health Connection, will be there to provide plans for people to be able to pick and choose what's most appropriate for them. Any information about whether somebody has or doesn't have health insurance will actually not be going through the Maryland Health Connection or the Maryland Health Exchange. That's not within their mandate. Now, every single individual submits tax returns, and that goes to the comptroller's office, and there is a checkbox. As we have right now, we have a checkbox that says, does your child have health insurance? We've had that for several years, and if the answer is no, then the comptroller directs information to be sent about how you enroll your child in health insurance. Not mandatory, but something that was done as a service. Same thing, there will be a checkbox, do you have health insurance? So the exchanges will not be collecting that data in Maryland. The exchanges in Maryland serve as a clearinghouse, as Hadley said, for health insurance plans that have been proposed to the plan that for people who may not want to get health insurance on the open market or can't get health insurance on the open market.
Yeah, I've heard it described as the Expedia of health insurance.
That's kind of the way that it's been set up. Now, the navigators are actually, in Maryland, the state's been split up into about 6 or 7 different regions, and a navigator agency has been determined to be in each one. So we're not talking about private health insurers. We're not talking about health benefits producers. We're talking about in Montgomery County, for example, it'll be the Department of Health and Human Services. And so in Montgomery County, there is this agency that will be set up within county government to be able to direct people on how to best to utilize the exchange. There will be, you can go online. For those people that don't want to go online, they can call in, or they can stop by the navigator's office at the Department of Health and Human Services in Montgomery County government to be able to sign up for a plan. The other option that we have in Maryland is we will have something called the Shop Exchange, which it's going to be on a slightly longer delay, and that's for businesses. to be able to go and shop just like an individual can in the regular exchange. A business can shop in the shop exchange, and SHOP is an acronym, and I forgot what it stands for, so
Small
don't ask.
Business Health Opportunities Program.
There you go.
There you go.
And that will be available to businesses as well. For any business under with 50 or fewer employees, if they want to provide health insurance, they can. They don't have to. But if they want to and they can't afford it, there will be subsidies in place that will allow them to be able to help afford it for their individual employees. Over 50 employees, you will be required to get that insurance. And if you don't, there will be a fine associated with it per employee.
So what is the incentive for an employer with 65 or 75 employees to provide the insurance if the insurance is going to be more than the fine? If the cost of the insurance is more than the fine, because we've heard of that, right?
Sure.
What's the incentive for that employer?
So the first thing I want to say about that is that we're talking about a very small pool of employers. The vast majority of employers already provide health insurance to their employees, and the ones that don't, for the most part, will go ahead and comply with the plan. We've heard a few examples of some very splashy news articles about whether it was Darden Industries, which is a restaurant chain, or some others, primarily in the restaurant industry. What you get is you get employees who are healthier. They take fewer sick days. They turn over less because they have a health benefit that they can take advantage of, and so you don't have to go through the retraining and rehiring, which is incredibly expensive for an employer to do. You get employers who are healthier when they're at work. So especially if it's a low-income job, people don't want to lose time off of work. They need the hours, and so so they'll come into work sick. These are all benefits that will benefit an employer tremendously in terms of their employee satisfaction.
And I would say traditionally the reason we've seen employers offer health insurance benefits are sort of twofold. On the one hand, it's a competitiveness issue. You want to be able to offer a job with a competitive salary and benefits package comparable to what someone may find with another employer.
Sure.
And the reason we have large-scale, employers doing this on the large scale is because there's a tax advantage to getting your health insurance through your employer. We have that money is tax exempt versus individuals pay for their health insurance with post-tax money, and that's what I do. You mentioned Expedia of health insurance, and that's actually how I found my health insurance, and that was PO or pre-Obamacare. There were clearinghouse type websites that would allow people to compare their plans and buy online or connect with a carrier online. So that to me raises the question: why did we need government to get involved with setting up these state-level websites or state-level clearinghouses if the private market could provide something comparable?
So let's ask the man in government.
Yeah.
Well, because the private market wasn't providing it. I mean, we had tens of millions of people in this country without health insurance. And so clearly there was no incentive, no ability to go and get health insurance, even if there's a website where you may go and compare a couple of plans. There wasn't the affordability, there wasn't the subsidies, there wasn't the requirement to be able to go and have to get it. I have a car, I own a house. I'm required to have mortgage insurance. I am required to have car insurance because that is considered to be a part of a responsible car owner, a responsible homeowner in case something should go wrong. The difference is not every person needs to buy a car. Not every person needs to buy a house. But every single person in this country, without exception, will take advantage or will have to be involved in the medical access system, without question.
Sure.
One of the other advantages that an employer gets is they get to write those expenses off on their taxes.
Right.
Those are corporate expenses.
So,
Yeah, I mean, we definitely do that. As employers, we have 70-ish employees or so, and we do offer health insurance. I think one of the most difficult things, and we just went through this with a rebid. One of the most difficult things is that our health insurance premiums as employers are not going down. Even as our population in our company gets healthier, and even as we have people who do. I mean, when we have people who access the healthcare and they get healthier, and we're in a healthcare industry, still it's going up and up and up and up. And I think for me, the thing that is the most troubling about Obamacare is that we call this the Affordable Care Act, and for me, it's an insurance bill. It's an insurance law. There's very little in there, and we haven't even gotten into this, and we'll get into this in our next episode. We haven't gotten into actually how this is going to affect quality or how we need to impact quality in healthcare, and that's something that we talk about
all the time,
in our company.
And you know what? I agree with you guys that there's a lot more that needs to be done. This bill by no means solves all of our healthcare problems for the next 100 years.
Isn't that scary? Isn't that scary that this bill is, how many pages was it, 2,700 or something? There's 10,000 pages of regulations or whatever there is. Isn't that scary that, look, we live in the healthcare system. We live in the healthcare system as much as anyone. But isn't that scary that there's still so much that has to be done that this law, hasn't done?
But to me, that's an indication that the law is a step in the wrong direction. You know, the more I study the healthcare system in the United States, our payment structure, the involvement of insurance, the more messed up I think that it is. So I agree that there are significant and serious problems that need addressing, and Kirill's right to bring up the nearly 50 million people who are without insurance. There are ways to make insurance more affordable and to encourage people to buy some sort of catastrophic health insurance without some kind of federal government mandate. There are better ways to solve these problems in our healthcare system, because when we have a complex multi-party payer system that's bloated with waste and bloated with people not having the right incentives to choose the most competitive, high-value, quality care for themselves and their families, then we are facing a situation where perhaps we ought to look back at policies that are as old as World War II and look at undoing some of that government involvement in an industry that is very personal.
Just because they need to provide coverage, if you've got 50 or more employees, just because they need to provide coverage, does that mean they need to provide 100% of the coverage? Or could they, pay 50% of the premiums for their employees, and then the employees could pay 50% to help reduce or offset some of those costs? So just, we only have like 30 seconds left.
They don't have to provide 100% of the coverage. And for example, when I'm not a delegate, I work for a private company like almost everybody else in the General Assembly. We are a part-time assembly. My employer provides health insurance, and in fact, we just had our debrief with our benefits provider about open enrollment coming up. And again, they said this is how much we're providing. In our case, it was 80%, I believe, or 70%, and this is how much you kick in. The same applies. You don't have to provide 100% coverage, but you do have to provide access to the plans.
Okay.
And you do have to provide some costs, but you don't have to fit the entire bill. But the one thing I want to clarify, though, catastrophic care is a great thing. I think if people have catastrophic care, it will buttress any kind of disaster that might befall. But having just catastrophic care will not improve health outcomes under no circumstances, because people need to be able to go see a doctor before things are a problem. Getting treatment for cancer is expensive. Getting treatment before you get cancer is not nearly as expensive. And having coverage before things are a problem is how we're going to actually get health improvements in this country.
Well, folks, a great way to end this show. Thank you so much. I agree. I thought that was a great final statement. Stay tuned for next week, because we're going to talk about how to improve the system and how to improve quality. Thank you so much for joining us on Living Healthy. We'll see you next week.